Welcome everyone to tonight's call. I titled it Cracking the Thyroid Code. We're going to talk about many things thyroid tonight because if you're an autoimmune patient in America, you are likely to have Hashimoto's disease because that's the most common autoimmune disease in America. If you have autoimmunity that isn't Hashimoto's, well, I realize there's over 100 other ones, so you may have something other than Hashimoto's, but you probably know somebody that has thyroid dysfunction, hypothyroidism, Hashimoto's disease, maybe even hyperthyroidism. And so on tonight's call, I want to talk about thyroid physiology, diagnosis, and lab work because the conventional medical model is very scant in terms of addressing thyroid, and we'll get into why that is and what that looks like. So welcome. And what I'd like to point you at is if you haven't read my book, The Autoimmune Answer, Chapter 7 is on the thyroid and covers all of the information I'm going to cover tonight and more. So if you'd like to review that or learn about other autoimmune diseases besides Hashimoto's disease, check it out on Amazon. There's an ebook, paperback, audiobook, however you like to consume it. And this is a graphic from that chapter. And so, one of the problems or a classic presentation in people with thyroid dysfunction is the frustration that they've seen many doctors and they feel terrible, but the doctor tells them their thyroid is fine or the thyroid is, quote, normal. So they're frustrated because they leave that office saying, Doc, I don't feel any better than when I walked in or any better than I felt in the last months to years, but you're telling me my thyroid's normal. However, my symptoms scream hypothyroidism. I have hair falling out by the handfuls. My nails are weak. My skin is dry. I'm constipated. I might have brain fog or anxiety. I can't lose weight. My hands and feet are cold. There's a bunch of potential symptoms because the thyroid sets the metabolic rate for every cell in the body. So part of the disconnect is diagnostic criteria for hypothyroidism. Conventional medicine, you can see here, I made this graphic because different studies and different doctors' offices call different things hypothyroidism. Now, the most generally well-accepted definition of hypothyroidism is the black circle, where you see a TSH level, thyroid stimulating hormone level, greater than 4.50. 4.50 in both LabCorp and Quest Diagnostics, which are the two largest nationwide labs, their upper range of normal is 4.50. Meaning if you're 4.51 or higher, that is a lab high result. And if you are having thyroid symptoms and you have lab high TSH for the first time, that's pretty much diagnostic criteria for hypothyroidism in the US, and usually results in prescription of levothyroxine or Synthroid, which is a T4 thyroid hormone replacement medication. I say usually leads to that. Well, different doctors' offices do things differently. The research shows that some doctors don't prescribe thyroid replacement until your TSH is 10 or higher. So you could be suffering for a long time before a given doctor's office is going to give you thyroid hormone replacement. Or there's some offices that say you could be up to a 6 in terms of TSH and aren't diagnostic for hypothyroidism. So that gray area is from normal range on the lab, right, at 3, all the way up to lab high at 6, and you're not being diagnosed and you're having symptoms. So that would be the subclinical hypothyroidism criteria that some doctors follow. And then, per the normal range on the labs, the white circle is 0.45 to 4.5. That's quote unquote normal TSH level on the Quest or LabCorp labs. And that's considered euthyroid. And euthyroid just means good thyroid. EU means good. So good thyroid. So you can see there's lots of gray area. There's really like 50 shades of gray in this diagram, right? Or should be. And so this is part of the problem with, and part of the frustration for patients with thyroid issues is that there's, you know, even though we have a defined normal range by the labs, a given office has their own criteria. And so depending on the office you go to, you may or may not be diagnosed sooner or later, and therefore helped sooner or later by the medical system. And even if you are diagnosed and prescribed Synthroid, you may not be helped because there's 24 different patterns of hypothyroidism, and only one of them is the drug the right choice by itself. Okay. Other ones, the drug may help, but you will require other things to be addressed at the same time. And so we're going to dive into that today. So thyroid physiology. Let's draw it out for us so we understand why a TSH level isn't enough. And you all may have seen a video I've made on YouTube where I talk about lab interpretation, and I use TSH as an example because it's very common, like we said, for a woman to have, or a man, a thyroid patient to have normal TSH levels, but be a screaming thyroid patient. And the reason why they're not helped is because conventional medicine uses a thyroid panel, quote unquote, but their thyroid panel is TSH. That's it. Sometimes they'll run a free T4 as well, but to get any more than that, you really have to ask, barter, and beg. Okay. And what you're going to learn today, and if you read my book, you learn that a full thyroid panel is actually 9 markers. So conventional medicine runs most of the time 1/9 of the equation, sometimes 2/9, and says you are or are not good. How can you use 11 to 22% of the information, 1/9 or 2/9, and say that someone is or is not something, right? There's 80% on the table that still hasn't been addressed. So we want to ask all 9 questions, run a full panel, so we can with confidence tell a person your thyroid's good or it isn't, and it's this type of pattern or this combination of patterns. So in order to understand why we need 9 markers and why Synthroid might not be what you need if you're having thyroid symptoms, we need to understand thyroid physiology. And to do that, I think we should do some artwork. So I'm going to jump over to the whiteboard here, and we're going to draw thyroid physiology. So one thing to understand is everyone, you know, when you're talking about a thyroid, everyone thinks of the thyroid, right? Because the thyroid is this butterfly-shaped gland in your neck. And that's what's making thyroid hormone. So that's where we focus, right? Or that's where conventional medicine focuses. And it kind of makes sense because we're a very cause and effect focused culture. But what we have to understand is that the thyroid gland and all of our endocrine glands are part of the endocrine system. The thyroid, the adrenal glands, the ovaries or the gonads. So by being part of the endocrine system, the gland itself is actually just the assembly line worker, okay? The actual management or the people running things are up in the brain, okay? And it's the command center is called the hypothalamus, and then the vice presidents are the pituitary, okay? So to orient you here, here's our patient. Oh, sorry for the witch nose. All right. So we have what's called the hypothalamic pituitary thyroid axis. And if you're into reading health blogs and you research the adrenals, you've probably heard the HPA axis for hypothalamic pituitary adrenal axis. There's also a hypothalamic pituitary gonadal axis. Excuse me. So the reason I tell you all that is that key to all of those is the HP part, the brain. If we leave the brain out of it, we're missing a huge part of the picture. Why? Well, the hypothalamus is the thermostat. In any endocrine system, if we're talking about thyroid or adrenals or gonads, it's a negative feedback system, meaning the brain's going to tell the gland to make it. The gland makes it. It goes out to the body, has its effect, and then the cells report back, hey, we have enough or we need more. So if the cells have enough, the hypothalamus picks up on that and via the pituitary tells the gland to slow down. We don't need as much now. If the cells say, hey, we need more, the HP axis is going to tell the gland make more. Okay, so what does a full thyroid panel look like? A full thyroid panel is 9 markers, and we want to understand what those are, and we do that by understanding the physiology. So out in the blood, out in the system, we have thyroid hormone levels. The hypothalamus is picking up on that. Hypothalamus is the thermostat, so it's checking levels. And let's say that there's not enough. So the hypothalamus says, hey, pituitary, we need more thyroid hormone levels. So it tells the pituitary through thyrotropin releasing hormone to tell the thyroid make more T4. Okay, so the pituitary releases thyroid stimulating hormone, or TSH. That's that marker that is on your labs if you're going to your doctor and getting your quote unquote thyroid panel. Pituitary releases that thyroid stimulating hormone to stimulate the thyroid gland to make more T4. The thyroid will obey orders, and it's going to take iodine and an amino acid called tyrosine, and through an enzyme called thyroid peroxidase, it's going to make T4. 93% of what the gland makes is T4. But T3 is the metabolically most active form of thyroid. So if the gland only makes 7% T3, the rest of our T3 has to come from T4. And that T4 must travel to the body. And it happens all over, but let me erase that. Thyroid conversion happens all over the body, but the majority of it occurs in the liver and in the gut. So the T4 travels to the liver and the gut and gets converted to T3. And then the final step is that T3 must bind our cells. So when it binds a receptor on our cells, it then goes into the DNA in the nucleus, and we get a proteomic response, we get a metabolism. And then it feeds back up here to the brain, and the hypothalamus says, hey, we have some, okay? So you may have seen on the labs, there's a T4, there's a total, and there's a free, okay? So let's understand that. The total, and there's a total and a free T3 as well. The total forms are the free form of the hormone that is riding on a protein called thyroglobulin. And I'm just going to write TG for thyroglobulin because writing it with a mouse would take forever. Okay. So thyroglobulin is a protein carrier for the free hormone fraction. Okay. So when the free hormone is on the thyroglobulin, it's called total T4. So my metaphor for that is, you know, free T4 hops onto a protein Uber. Now it's total T4. That protein Uber drives it around to wherever it's going in the body. It jumps out and now it's free and it does its work. Okay. So we have total, we have free. Well, the free fractions are what do the work, whether it's free T4, free T3, whether it's free testosterone, whatever hormone we're talking about, the free fractions do the work. There's one other marker we need to know. T4 can go to the body and be converted to T3, or T4 can be converted to what's called reverse T3. And reverse T3 is the evil twin of free T3, say. Okay, so let's look at them as Cain and Abel. Okay, reverse T3 is Cain, is the bad guy. Free T3 is Abel, it's the good guy. So if Abel and the cell that is looking for thyroid hormone is the girl, is the prom date. Okay, so the two brothers are competing for the same girl. If Abel gets the girl, there's magic there because the girl likes him, they bond, and we have a metabolic response, and yay, thyroid happens. If Cain gets the girl doesn't like him. So he binds her receptor, but she fights back. She's still not going to go to the date with him. But what happens is that free T3 doesn't bind her. So we don't get the magic. We don't get the thyroid response. And so what can happen is because free T3 didn't bind the cell, the free T3 level in the blood looks okay. But your cell feels hypothyroid, still feels bad, right? Because it never got what it needed. So you could be tricked into having a doctor that actually ran your T3s. It's like, oh, hallelujah, I got a doctor to run my T3 levels, but they look great. And I'm disappointed because I still don't feel as good as I should if they look that good. Well, these are blood levels. They have to bind the cells to have the effect. And if reverse T3 is preventing that binding, you may have good blood levels, but feel bad. And that's the mechanism. Okay. So we want to understand, well, why is reverse T3 outcompeting free T3? Why is reverse T3 high? That could be stress. That could be inflammation. That could be different immune responses. But if you don't test it, you don't know. Okay. And then that's one pattern. Another pattern is conversion issues. You know, if medicine just runs TSH and it looks okay, you could leave frustrated. If they run TSH and T4s and they look okay, you could still feel bad and leave frustrated. Why? Well, one reason is because if you have good T4, but you don't feel good, maybe you're doing what we just said. Maybe it's being converted to reverse T3 and we're not getting T3 binding sufficiently to cells. Or another mechanism that could be happening is that you're making enough T4, but remember, the gland only makes 7% T3. So to get enough T3, you have to convert the T4. Well, perhaps you have a conversion issue there. Conversion isn't happening efficiently because you have a gut issue, or you have a liver issue, or you're lacking nutrients that the enzymes for conversion require, or you're inflamed. Okay, so there's multiple reasons peripherally why you can feel hypothyroid, even though glandular production looks okay. You could have autoimmunity. So Hashimoto's disease is thyroid autoimmunity, and there's two potential targets that we see in Hashimoto's. There's TPO, or thyroid peroxidase antibodies. There's thyroglobulin antibodies. So you might be attacking the enzyme that's needed to make the T4, okay? And or you might be attacking the Uber that's needed to carry the hormone around to the cells of the body so they can have their effect. So these are the 9 markers we want to see. We want to see TSH. We want to see total and free T4. We want to see total and free T3. We want to see reverse T3. We want to see thyroglobulin. We want to see thyroglobulin antibodies and TPO antibodies. Don't worry, I have it on the next slide. You don't have to write it down. But this is the physiology. So if things are working, right, if thermostat ends up telling gland to make it, gland can make it fine, it can be converted fine, it wins the girl fine, then we get feedback back up to the brain, hey, turn it up or turn it down based on needs. Remember, thyroid sets the metabolism of every cell in your body. Your metabolic rate is dynamic depending on the demand you're putting into the system. So sometimes you need more, sometimes you need less. So when you're testing, you also want to know, what was the relative demand around the time of testing, and is that appropriate for you? So there's all these variables. Well, if you're only running a TSH and that's it, well, then we're not going to get any of this. We're not going to know what's going on. So if this happens to look okay, you leave your doctor frustrated. I feel terrible, but my TSH is fine. Thanks a lot. Now what? So let's jump back to the presentation now. So that's the thyroid physiology. And here's a cleaner picture of what a true thyroid panel is. The thyroid panel is in parentheses because conventionally that's a TSH, maybe a free T4. A true thyroid panel is all 9 of these. Okay, it's important to get these so that we can then interpret, we could draw out your picture and interpret it correctly so that we know, hey, does this person need medication? Or do they need, you know, say liver or gut support to improve conversion and they don't need medication, or do they need both and what have you? So there's various layers, and you may have multiple layers because humans don't present as textbooks very often. So your doctor has to be able to interpret these things and understand the rest of your physiology too. And that's why we don't run just a thyroid panel by itself. We also want to understand the rest of the physiology because blood sugar can impact it, sex hormones can impact it, stress can impact it, inflammation can impact it, autoimmunity, nutrient deficiencies, etc. So if you'd like to learn more, I have a thyroid playlist on my YouTube channel where I cover various topics, have testimonials and things like that regarding the thyroid physiology, etc. So I point you that way. Check that out. Check out the book. And, you know, if we can help you, reach out at functionalmedicinecharlotte.com. Let's open it up to questions.
Is that all of those are markers that you test for? Like for me, you did all those.
Yeah. Yeah, those are markers that are standard in my mind. Like I'm running those on everyone the first time. There's not a lot of things that I do to everyone, but that's one thing because it's usually the first time it's ever been done. And again, the thyroid is so commonly involved that if you miss it, you're going to miss being able to help the person the way they need to be helped. So yes, I check those up front every time. At reevals, maybe not. You know, it depends. If you're good, then no. You know, but at the big reevals, we'll check in. But you know, if we've checked in a few times over time and you've never had antibodies, well, then we don't have to keep doing that, right? Unless something changes.
I have a question.
Yeah.
I'm sorry.
Oh,
Go ahead.
go ahead.
Go ahead.
Okay. Because, you know, I had the Cain and Abel problem.
Yeah, girl.
So, what, like, you know, I think it's with kind of everything, but, you know, we got that fixed.
Mm-hmm.
And how do so do you just feel pretty good about continuing on your plan once we get to a certain point, and that will kind of stay the course, you know, keep Cain away from my good guy?
Yeah.
Okay.
Was that a question?
Yes.
Okay. So how long do I expect it to stay good for you, or in general, once you correct it, can we assume it's corrected?
Let's start with in general, since I'm so crazy.
Okay. I wonder if that's, let me see. I haven't done it like this before, so I wonder if the drawing's still there. 3, 2, 1, please. Yes. Okay. Good. And let's do this. Oh, wow. Well, okay. We have undo functions. That's awesome. All right. So, Jennifer, this goes up. So the reverse T3 will go up because of stress, inflammation, a Th17 immune response, that sort of thing, right? So what we need to do is figure out in the individual why or what variables are present driving this up, and then can we address those, right? So if it's, say it's a Th17 immune response, which, can I share about your case?
Yes.
Okay, so Jennifer's someone that has MS, multiple sclerosis. MS is an autoimmune disease. Autoimmune diseases are driven by a Th17 immune response or imbalance or bias. So you all may remember I've drawn you a seesaw at some point with different Th phenotypes on it. So if your seesaw is imbalanced, you know, if Jennifer's has a high Th17 and say a low Th1, well, the longer this stays high, we're promoting reverse T3, okay? So what's cool is if we can balance her immune system out, not only do we help her MS, but we also help her thyroid physiology because we reduce the reverse T3. So, you know, you're affecting global physiology by impacting this, okay? Or impacting this, which we did by impacting this, and vice versa. Make sense? So if the next person, if it's high because of cortisol, because, you know, a bad relationship or news cycles, or they work third shift and are sleep deprived or whatever, you know, it's figuring out in that case, what is the thing or things contributing to that? Make sense? And if we can correct it and keep it away, then we would expect it to stay down, right? And so to Vicky's question, how often, you know, so if we get to optimal or you know, Jennifer reached Dixie Cup status recently, you know, actually it's way bigger than golf clap. It's like, yeah, okay. But when you're a Dixie Cup, now it's okay, hey, in 6 months, 12 months, let's run labs again, catch up and just check in. Okay, so at those tests, we would run this again because it's been 6-12 months. Let's just see where you're at, right? And you know, because you don't always just go, if someone regresses, they don't always go way worse back to where they were. Maybe they just creep back there. Well, again, let's stop it before we get back to that point, right? And that's why you don't want to just run a thyroid panel. If I'm working with Jennifer, then there's certain markers over time that we realize are contextually important in her case. So we always want to look at those. And when we figure those out, we might not have to run a bunch of the other stuff because we know her case, like her physiology, here's how it speaks to us through these markers, right? And so when we understand that about a person, we can be more efficient with labs and do that and add more if symptoms change or something new happens.
What is the medication? Like my sister and my mom both take some sort of thyroid medication. I have no idea what, and have for a very long time. What exactly does that do?
Yeah, good question. Let me try and do this without the mic picking up every click. So the medication typically in conventional medicine is T4 replacement. Okay, so it's called levothyroxine is the, you know, or Synthroid, same thing. Or Tyrosint is the clean version, much pricier but cleaner. And so what they do is they give them T4 and say, you know, good luck. And it's T4 for the rest of your life. And the reason that, you know, some of you out there may have had an experience of hypothyroid symptoms and you end up having Hashimoto's, and it's like, well, why didn't they run antibodies before? Or why don't they care about my antibodies? Or you may have gone to an endocrinologist and said, I have Hashimoto's, and they're like, well, whatever, come back when you need a procedure, which would be removing the thyroid or irradiating it or whatever. The reason they don't really care is because it doesn't change treatment. They're giving you T4 replacement regardless of how you present, okay? Which again, if there's 24 different patterns of hypothyroidism, well, let's be a little bit more specific, can we? Right? Because everyone doesn't have the same pattern, and the hormone replacement isn't the right answer for most of them. Okay. Vicky, there is T3 hormone called leothyronine or cytomel. Okay. And that is used way less often. I've referred a couple patients to go get it because if their labs show over time consistent conversion issues where, hey, we've cleaned up gut, we've cleaned up liver, like we've done the work and they're still not converting to the level we need them to, well, then sometimes just the lowest dose Cytomel is enough, you know? And so matter has limitations. I'm not here telling you that medications aren't necessary, but we want to use them appropriately, right? Just like, you know, we want to use supplements appropriately. Sometimes you're beyond supplement help and you need medication, but sometimes we're giving medication to people that don't need it, right? So it's figuring that out. And how do we do that? Well, if we can get as thorough a look as possible, we can be more successful at doing the right thing for the right person at the right time. Does that make sense?
Mm-hmm. Yeah.
Did that answer the medication question?
Yeah, my sister will use her medication to sort of adjust her weight.
Yeah, which is interesting. Actually I had a consult with a lady today who she's got Hashimoto's. How long has it been? It had been years, and she's on T4 replacement, which is standard in conventional medicine. And she said, you know, she thinks, so her main symptom is anxiety. So she feels that if she takes the dose that the doctor recommends, it drives her anxiety, which anxiety you can have with too low thyroid or too high, okay? But when she takes her hormone to the dose that the doctor recommends, her anxiety goes up, which suggests she's over medicated, right? Or hyperthyroid. So if she doesn't take it at that dose, she feels better, but her labs drop. And it's like, well, you know, and she's like, well, what do I do? And I said, well, you know, this whole, everything under this red line, well, and this part too, has not been tested on you. So we really can't say without asking the other 7 questions, you know, what's going on here. Because I said, well, when your labs drop, what does that mean? Are they just looking at TSH and free T4? Because if so, you know, we need to know, well, what are your T3s? And what's your conversion? What's your revert? You know, you have Hashimoto, so are your antibodies, have they gone up significantly, and are you having a Hashimoto's flare and it's not your medication? You know, so those are the things that we need to figure out in that case.
What do you think of Armor Thyroid and Nature Thyroid?
Yeah, so Armor, those are glandular hormone replacement. So essentially it's pig thyroid, desiccated pig thyroid, and they'll contain T4 and T3. And for some people, those work. It depends on the person, Janelle. And I'm not saying that as a cop out. I'm saying that because hormone replacement, synthetic hormone replacement, pharmaceutical hormone replacement is synthetic. So that's made in a lab, and you know, it's not natural. So the body doesn't necessarily recognize that. But the desiccated glandular thyroid, that can look close enough to our thyroid that you have what's called sequence homology or molecular mimicry, or basically half the sentence of the pig thyroid looks close enough to half of a sentence of our thyroid that if you have autoimmunity present, your antibodies might target the Armor. So taking Armor might cause a flare in a Hashimoto's patient. Because if you think about it, you're dumping down more target for the antibodies to look for. Does that make sense?
Mm-hmm.
So if someone's got Hashimoto's and they take Armor and like, oh, I did way worse on that, that's might be the mechanism.
Have you been able to get anyone off of thyroid hormone who has Hashimoto's? I mean, not that you prescribe, but like,
yeah,
get them to, you know what I mean?
Yeah. So it's outside my scope to put someone on or off of medication. So the goal is to reach optimal health, track it with labs so that we can have a conversation with the prescriber. Hey doc, you know, when Vicky's on her meds, so here's the changes we've done over time. Here's the lab showing it, right? Across physiology. So now when Vicky takes her medication, she's getting hyperthyroid type symptoms, which suggests she's over medicated. You know, can you have the conversation with her of you know, maybe titrating it down or coming off? A very common experience I have with patients is patients on blood pressure medications. As they get healthier, they start feeling dizzy and lightheaded, which is a sign that they're over medicated or they're pushing their blood pressure down too much. So then we have to speak with their prescriber, share what they're experiencing, show them the labs, show them the blood pressures they've been following, you know, and then it's, you know, it's not really, it's kind of a no-brainer at that point for the prescriber to say, yeah, let's pull you off. Not as common with the Hashimoto's, because oftentimes in the conventional model, someone's got Hashimoto's for years, which is allowing years of damage to the gland before they finally, you know, work with a weirdo like me, right? So at that point, matter has limitations. So there might be enough glandular damage that they need the medication at this point, you know, they can't do without it, I should say. So at that point, it's, hey, can we achieve a level of health that provides us the ability to give them the lowest dose possible with the maximum benefit?
Right, right.
Are thyroid levels tested at 6 weeks?
If necessary. Yours weren't.
Because I'm wondering if when I first was diagnosed with low thyroid, I was on Synthroid. And then I thought that I did some research, and, you know, like you said, they don't test for everything. And I thought, oh, I'd like to get on something more natural. And I asked to be put on WP thyroid or nature thyroid, something like that. And I'm wondering, as I'm getting healthier, is it contributing to my weight loss? Is it, you know, hard to gain weight because of it? And that's just something.
That's a definite possibility, biologically plausible for sure. And it could be contributing to anxiety.
Yeah.
So, you know, you go and you look, we could test it, or your GP who's providing you with that medication could test it, and you say, here's my symptoms, you know, the weight loss being one, anxiety being one, and what was my level.
But they won't test for everything, and you will.
Likely.
Yeah.
Yes to I will, if necessary, and likely that they won't.
Right. They really don't. And I was reading about the TPO level, and I had to, like you said, put up a little bit of a stink to get the TPO tested. And they kind of just look at it as, well, if they're high, what different, you know, it's gonna be high regardless of whether you're 5 pounds overweight or 15 pounds overweight, you're overweight.
The TPO is going to be high, you're saying?
Or when they test for it, and that's why they're not so concerned about testing for TPO.
Yeah, but the problem, what you have to, not you, but what we have to understand is that if TPO and or thyroglobulin antibodies are present, if autoimmunity is present in the case, and you're giving them Synthroid, which is T4, okay, all that's doing is basically suppressing symptoms. So you're duct taping over the victim's mouth. They can no longer scream, okay? But the perpetrator is still damaging them, right? When it's autoimmune, it's no longer a primary thyroid issue, it's a primary immune system issue. So it absolutely matters, because just giving thyroid hormone replacement says, have your way. You know, you're actually complicit, right? Because you're duct taping and allowing it to continue to happen.
Right.
So it absolutely matters if it's present, and that's why, you know, people don't get better like over time, those people don't get better, they get worse. And, oh, I started at 50 and now I'm at 88 and now I'm at, 110 micrograms or what, dose. The dose goes up over time because they don't feel as good on the dose they started on. Well, probably because matter has limitations. And as we continue to smash this thing, the body has less resilience to keep up. So now you need more artificial to keep you where you were, which still isn't even good. Make sense?
So how do you get your GP to test you for the 9 thyroid things? That's the real issue, because, the insurance and all of what everybody's concerned about, they don't want to do it. They don't even want to test for vitamin D. If you've had good vitamin D levels, the appointment before, insurance doesn't feel the need to cover it. But then how would you know that you're still at a good level of vitamin D? It's just, I don't know.
Well, it's a reactive system. So you'll know once your D is deficient again, and then we'll give it to you again. I had some snide remarks, but those wouldn't help anybody. I think it's just the model is, here's the diagnostic criteria, right? And diagnostic criteria is lab high TSH, and you have symptoms, you have hypothyroid. Here's what we do to hypothyroid, okay? Whether you have antibodies or not, or you have Hashimoto's, here's what we do to Hashimoto's, which, is the same thing we do to hypothyroid. So if you want something different than that, you have to go outside that model. Most times, there are MDs who are learning functional medicine and getting into it, and that's awesome. But still, you're not likely to have insurance coverage there because it's still insurance-wise medically unnecessary or above standard, or whatever they term it. So you'll ultimately need to. You got to find someone who's willing to do it and understands it.
That was a fantastic explanation of the autoimmunity there. Just
thank you.
The duct tape. I mean, not just thyroid, but that's exactly what they do. That's all it is. It's just, well, this looks good to us on paper. We don't need to dig any further. That's it.
Yeah, and that explanation's in my book, by the way. As a general explanation, I use the thyroid model, but it's autoimmunity. That's how it's treated across conventional medicine, is they're affecting the gland being attacked. Okay, so it's the thyroid, or it's the brain in MS, or it's the parotid gland in Sjogren's, or it's your joints in RA. It's all, how can we make your joints hurt less? How can we make your mouth less dry? How can we make your neurologic symptoms, how can we make your vision, how can we make your eye not hurt, not your vision better, right? So whereas if we would just say, this fundamentally is an immune system problem, stop paying attention to where the symptom is, pay attention to what the cause is, then we'd get better results. And that's the magic sauce. That's why I can help you see in 3 weeks when they couldn't in 8 months. It's just because I went after what's actually happening, and they were just trying to help your eye not burn.
And that is a true story.
Yeah. So again, it's like, well, let's get to the cause. And unfortunately, if we get to the cause, you're out of the system because you're now healthy. And the system is a reactive, repeat business system. And that sounds like conspiracy theory, but it's observe the system. Like, it's not about health. It's about, okay, let's have you follow up. We'll rerun it. We'll titrate your dose. We'll go from here. And if you ask them a question like this, ask next time you see your doctor, ask them to draw the thyroid pathway for you. It'll be really entertaining.